So today, let us look at malaria, as we are still looking at conditions that affect the blood. Let us look at malaria. So malaria is one of the most common life-threatening tropical diseases in the world. This condition causes approximately 500 million infections and more than 1 million deaths each year. Okay. It is one of the commonest diseases in tropical countries and is responsible for a lot of morbidity. Okay, so it comes from the Italian word which means bad air. It is transmitted through the bite of an infected female mosquito, which belongs to a family of Anopheles mosquitoes. So we have three species in Zambia, and these are all transmit these can transmit three species of these flies which can transmit malaria. Okay, so these three species include Anopheles gambier, Anopheles arabiensis, and Anopheles funestus. So these ones differ from one another from many other mosquitoes by being late night feeders. So these feed in the night, and these are the ones that are able to transmit malaria to human beings. Now, what is the definition of malaria? Malaria is a protozoa infection of the genus Plasmodium. This one is transmitted to human beings through the bite of an infected female Anopheles mosquito and characterized by paroxysms of chills, fever, sweating, splenomegaly, and a chronic relapsing course. That is the definition. Remember always to include what is affected, what really is the problem, the cause, and at least two characteristics of the condition that you're talking about. Now, what are the causes of malaria? So we were saying that we have 4 species of parasites that can cause malaria in humans. We have 3 species of the Anopheles mosquito that can cause malaria, but we have 4 species of the parasites that can cause malaria. The Anopheles mosquitoes can transmit malaria parasites, and the parasites that can cause malaria are 4 in number. Each species has a different biological pattern in which it affects man. Now, these species include Plasmodium ovale, Plasmodium vivax, Plasmodium malaria, and Plasmodium falciparum. And we're saying that one that is very significant, especially in Zambia, and very lethal is Plasmodium falciparum, and it accounts for 99% of all malaria cases in our country. So a Plasmodium malaria accounts for about 3% of malaria cases. Plasmodium ovale accounts for about 2%, and Vivax is one of the rarest forms of malaria. The mode of transmission of malaria can be both direct and indirect. So it can be transmitted directly through the bite of an infected female Anopheles mosquito, and indirectly through blood transfusion, okay, or through inoculation with a needle that was used to inject someone who has malaria. It can also be transmitted from mother to child placentally, from mother to child. Risk factors include children who are under 5 years old, HIV-infected individuals, pregnant women, okay? Find that the parasite will become concentrated in the placenta. And at times you find that this pregnant woman may not even feel the signs and symptoms, or they may feel the signs and symptoms, but they may ignore them, thinking it's because they're feeling that bad because of the pregnancy. So you find that by the time this human being is coming to the hospital for treatment, it may be too late. That woman may end up losing their child because we have said that the parasites concentrate in the placenta. The incubation period of malaria, meaning the time from which the human being can be inoculated with these parasites to the time they develop signs and symptoms, is about 10 to 14 days. And this depends on the species of the plasmodium. So what is the life cycle of a malaria parasite? Okay. The malaria parasite is complex. Okay, there will be divisions and there will be cyst formations. So part of this life cycle will be in the blood cells of the human being, and part of it will be in the liver cells of the human being, and part of it will be in the stomach and salivary glands of the female Anopheles mosquito. The life cycle part that happens in the human being is the asexual cycle, while the life cycle part that happens in the mosquito is the sexual cycle. So in man, this is the definite. So we're saying in man, we start looking at the life cycle of the malaria parasite in man. The definite host of malaria parasites is the female Anopheles mosquito, and this one is the one that acts as a transmission vector. So this female Anopheles mosquito will inoculate the parasite whilst it's having a feed, whilst it's feeding on the blood of this human being. It injects the parasites into the human being. The stage at which these parasites are injected in the human being, they are known as sporozoites. Okay, so these sporozoites will enter the bloodstream and they will go and enter the liver. Okay, now this stage, whilst they are in the liver, is known as a pre-erythrocytic stage or exoerythrocytic stage. And there in the liver, they are going to infiltrate the parenchymal cells of the liver. The word parenchyma means the cells that actually perform the actual function of that particular organ. So we are talking about hepatocytes in this case. So these hepatocytes will be infiltrated. In the hepatocytes, they are going to develop and multiply. Inside the cells, they'll develop, they'll multiply, and then they'll form schizons. These schizons will reproduce and generate numbers and numbers of what will now be known as merozoites. Now, within 2 to 3 weeks of hepatic infection, meaning within the time the infection is in the liver, the schizons, remember, initially we said they will develop and form schizons, okay? These schizons, inside there is going to be reproduction, which are going to produce merozoites. Now, in about 2 to 3 weeks, these schizons are going to rupture. Once they rupture, there's going to be release of those merozoites that have been reproduced. These merozoites will start flowing in the blood. They will start flowing in the blood and they will invade red blood cells. The red blood cells, once invaded, this stage is now known as the erythrocytic stage. Once they are in the red blood cells, they're going to grow, they're going to multiply, they're going to survive on feeding on hemoglobin. So within about 2 to 4 days of being in the red blood cells, these merozoites will mature. Once they mature, they are going to rupture the cell and they are going to be released in the blood again. Okay, once they are released in the blood, they will hunt out more red blood cells. They will enter the red blood cells, and that cycle will continue. They'll further increase in number. They'll go into the red blood cells. They will multiply. They will develop. They will break the red blood cells, and they'll break the red blood cells to release more merozoites, and that cycle will do what? Will continue. Now, when these merozoites are being released, when the red blood cells are breaking down by these parasites, the human being will now be having fevers and chills, and the patient will now develop those signs and symptoms, the classic signs and symptoms of malaria that we've always talked about. And we are saying that you are going to find that this is going to happen in cycles. It will happen, and once they go in, the patient will start feeling better when they're in the cells. As the cells are breaking down, those chills and fevers will start again. Now, some of the merozoites will differentiate. When they differentiate, they become gametocytes. Gametocytes are the sexual forms, okay? Gametocytes are the sexual forms. And once they are the sexual forms, it means they are ready to be picked up by a mosquito, okay? Now, with Plasmodium falciparum, the parasites in the liver die after the first release into the blood. So you find that after the first release into the blood, some of the parasites in the liver would what? Would die. But with other species like Vivax, Ovale, and intrahepatic parasite, the intrahepatic parasites do not develop. They'll remain dormant. All right. And they'll continue to live in the liver and they'll continue relapsing. Okay. And then you find that in these other ones, the patient is going to be having relapses of malaria within a few weeks and just like that. So in the mosquito now, remember at which point we ended where the merozoites have become gametocytes. They are now ready to be picked up by a mosquito. So in this case now, a female Anopheles mosquito that is not infected will go and take a blood meal from an infected person. The gametocytes will then be taken up together with that blood meal, okay? And the ingested gametocytes will further differentiate into male and female gametes. Then they will fuse in the gut of the mosquito. When they fuse, they will produce what is known as an okinate. That okinate will penetrate the lining of the gut of the mosquito and produce a cyst. Okay, that cyst is known as an oocyst in the wall of the gut of this mosquito. This oocyst is going to rupture, and once it ruptures, it's going to now release sporozoites. These sporozoites will migrate through the mosquito's body to the salivary glands of this mosquito. There, they'll be ready to infect another human being. Once this mosquito goes to have a blood meal on an infected human being, these sporozoites will be injected in this human being. So this is just a diagram of the life cycle. So here, this mosquito that has sporozoites is biting this human being at this point, and the sporozoites are released in the blood. These sporozoites will go to the liver as the blood is flowing. Obviously, it goes to the liver, and in the liver, they are going to infiltrate the hepatocytes, and there they're going to develop, they're going to form schizons, which are going to break down and release merozoites. Okay, this is an infected liver cell, and the schizons have been formed here. These schizons are going to rupture and they're going to release merozoites. Okay. Now, once the merozoites are released, they are going to go into the bloodstream and infect red blood cells. And these red blood cells are going in the red blood cells, there's going to be further multiplication, further development, and then they're going to be released Okay, that they are going to be to break down because there's going to be formation of chysons in the red blood cells. The red blood cells will be ruptured, and once the red blood cells are ruptured, more merozoites are going to be released. More merozoites are going to be released. This cycle will continue for several cycles until some of them will become gametes. Okay, some of them will become gametes, and these gametes will be now ready to be picked up by the mosquito. All right, these gametes will be picked up by the mosquito, and once they are picked up by the mosquito, they are going to go into the gut lining of the mosquito. Here is the mosquito biting an infected human being and picking up the gamete and then these gametes they are going to now go into the gut lining, okay, of the mosquito. They are going to fuse. Once they fuse, they are going to uh, form an okinate, all right, and they are going to then form an oocyst, which is going to comprise a lot of these parasites in them. Once this oocyst ruptures, it's going to release the sporozoites, which are going to migrate to the salivary glands of the mosquito, and they're going to stay there in wait for the mosquito to go and bite an infected human being. Right. So that is the life cycle. Okay. And now we have the pathophysiology. The pathophysiology of malaria results results from red blood cell infection. When the red blood cells are infected, this is where now the pathophysiology is going to come in. Okay, there will be destruction of the red blood cells, there will be release of parasites, the erythrocyte material into the circulation will be released into the circulation, and the host reaction to these events. And then because of this whole cascade, there is going to be the development of anemia, which we looked at the other day. We said anemia is reduced oxygen carrying capacity, because when remember, the red blood cells are the ones that have this hemoglobin which carries oxygen from the lungs to the rest of the body parts. And therefore, you find that malaria breaks down these red blood cells, and so the patient will end up with malaria. Therefore, one of the complications of malaria is anemia. Now, in Plasmodium falciparum, infected erythrocytes also sequester. Okay, this is a process where erythrocytes containing mature forms of the Plasmodium falciparum will adhere to microvascular endothelium and thus disappearing from the circulation. This is very dangerous. You find that these Plasmodium falciparum will start adhering to the endothelium. Remember, in anatomy, endothelium, that epithelial lining of blood vessels and the heart, okay? So that will have Plasmodium falciparum adhering to those organs. So you find that in vital organs which are supposed to have a lot of blood circulation, constant blood circulation, will have a hindrance of blood flow, because if tiny blood vessels have this falciparum attaching to their endothelium, it means that blood circulation will be hindered. These parasites will display adhesive protein on the surface of the infected blood cells, and this causes them to adhere to one another and to the walls of the capillaries. And this will happen in major organs such as the brain, the heart, the spleen, the intestines, the lungs. Okay, now this results in several things happening. But you find that there are these two major things. There will be sequestration, which occurs where parasitized erythrocytes attached to the endothelium, they will not circulate. So patients with severe falciparum have very few circulating blood parasites. So you find that because there are very few circulating parasites, you may even miss the diagnosis if you are not careful when you take the sample, especially if you're taking the sample from a large vein. So you find that you may miss the parasites, which is why it's advised that you take the sample, the blood slide from a peripheral, for example, a finger. So you find that most of the blood will be sequestered in organs, all right? The second thing that will happen is capillaries of deep organs become obstructed. So when they become obstructed, there is going to be congestion and there's going to be rupture. Now, when these small blood vessels start rupturing, there's going to be ischemia, hypoxia, and this will happen in organs such as the brain, the kidneys, okay, the lungs. So you find that these major organs are going to be hypoxic. Now, there is going to be increased vascular permeability, causing plasma and unparasitized cells to leak into the extravascular space, and this causes edema. Okay, there's going to be increased permeability because the blood vessel walls are deranged; they cannot function properly, and this will result in plasma and some cells to leak into the extravascular spaces. This human being will have edema. All this will lead to complications, okay, of malaria, such as cerebral malaria, black water fever. Okay, black water fever is where the human being will be urinating urine that is very dark in color, okay, because of the sequestration of the of blood and because of the increased breakdown of red blood cells. There is going to be severe anemia, okay, there's going to be hypoglycemia, all right, and pregnancies will be complicated because of these problems. Okay, so in summary, we are saying that the malaria parasite is the malaria pathophysiology is as a result of the several cycles of breakdown of the red blood cells. Now, we are also saying that certain parasites, okay, certain parasites such as the Plasmodium falciparum, these ones, this is the one that causes the most severe kind of malaria, and you're going to notice that in this one, these parasites have the ability to sequester. They have the ability to um, to cause the erythrocytes to attach to one another, to start adhering to one another as well as to the walls. So when these parasites are in these red blood cells are going to start adhering to one another, forming blood clots in the bloodstream, as well as adhering to the blood vessel walls inside the bloodstream in the endothelium, reducing the space, reducing the lumen through which blood is supposed to pass. This results in blood being stagnant in certain organs, and this is known as the sequestration. So when this happens, once these parasites cause the red blood cells to adhere to one another and to make the proteins to display adhesive proteins on the surface of the infected blood cells. These cells will cause these capillaries not to have blood passing through them properly. Now, when this happens, this will lead to this will lead to congestion in these organs, because even when blood is there, it's not going to manage to come out easily. So you find that there is congestion in these areas. However, the blood that will have oxygen will not be coming properly, and therefore these organs will end up having what is known as hypoxia, that is reduced oxygen in an organ. So you find that these organs will not have enough oxygen to that area. Not only that, the other thing that will happen is, because of the continued breakdown of the red blood cells, there is going to be hypoxia, there is going to be the kidneys are going to be affected, the lungs are going to be affected. The patient may end up having things like anemia. Okay, this patient may end up complicating pregnancies. So that is the simple pathophysiology of malaria. Now, what are the clinical features of malaria? So, disease manifestation is related to the rupture of the red blood cells. Okay, it is also related to the occlusion of capillaries in major organs. And then there's going to be also organ function impairment. The patient experiences several episodes of cold and hot attacks. And these cold and hot attacks are known as rigors. Now, we're saying that these cold and hot attacks are because of the cycles of red blood cell breakdown. At what point the merozoites are being released. At the point of the release of the merozoites, in that life cycle, you find that this patient is going to now have to have these rigors. Okay, so these rigors are divided into cold, hot, and sweating stages. So first of all, we're going to have a cold stage where the patient feels intensely cold and shivers with teeth that will be clattering. So you find that the patient's temperature will rise to as high as 40 degrees Celsius. Patients will experience vomiting and headache, and patient will this kind of this kind of symptoms will last about 15 minutes to 1 hour, and then they'll feel better again, or they'll go into a very hot stage where they now start feeling very hot. They're confused, they don't know what's happening, they become delirious, may even be in a coma. Okay, now, this one will occur 30 minutes after the cold stage. The patient may continue vomiting, may continue to complain of heat in the body. So you would want to put a blanket on them. They'll be removing that blanket because they feel very hot at this stage. And this stage will last for 2 to 6 hours. The last stage is the sweating stage. This one lasts about 1 to 6 hours. The patient sweats profusely and temperature will drop because the patient is sweating. And then the patient will start feeling better afterwards. Okay? However, the fever will recur after about 48 to 72 hours. So in about 2 to 3 days, the fever will come back. You find that the fever will come back. So those are the stages of rigors in a patient with malaria. So you find that sometimes you may misdiagnose if you do not have the diagnostic materials to use. You may think the patient is pretending because 1 minute they are okay, 1 minute they are very sick, another minute they are okay. So you should be very vigilant. Now, what are the other signs and symptoms of malaria? One, the patient will be malazed. They will have they will have malaise. The patient will be drowsy. This is due to malaise is due to tissue hypoxia. The drowsiness is due to cerebral hypoxia. Patient will have abdominal pains due to hypoxia. Okay, the organs of the body will not be receiving enough oxygen, and then there is also the sequestration of blood. Okay, so these organs will be painful. The patient will have hepatosplenomegaly. There is a lot of breakdown of red blood cells in the spleen, and then there is breakdown of blood cells and hepatocytes in the liver. So you find that these two organs are going to be enlarged. Patient will have anorexia, which is loss of appetite, and nausea. Patient will be fatigued due to tissue hypoxia. The patient may start convulsing if the brain is involved. Obviously, the patient is going to have headache, which is due to infection as well as hypoxia. The general body pains, patient will complain of generally being in pain. Patient will have joint pains, also known as arthralgia. The patient will have joint pains due to blood sequestration in the joints and tissue hypoxia. The patient will have a dry cough, and patient will be vomiting. The patient may exhibit jaundice. Jaundice is the yellowing of the skin and the mucous membranes. So you find that you look at the patient's sclera, it will be reddish in color. And so this patient, this jaundice is because of increased breakdown of red blood cells, which releases the red blood cell components there. We have byproducts of red blood cell breakdown, and one of those byproducts is known as bilirubin. Now, bilirubin is supposed to pass through the liver so that it is conjugated to make it soluble enough to be excreted. Okay, now once there is too much of this bilirubin, the liver is overwhelmed. And so you're going to find a lot of unconjugated, bilirubin flowing in the blood. Because of this bilirubin will start showing up under the skin and the mucous membrane. And so these patients' skin and mucous membrane will appear yellowish in color. So most patients with malaria have no specific physical findings, but splenomegaly may be present. So most of these will be things, most of the things that the patient will present with will be symptoms and not signs. You will not see it that they have malaria unless at the time when they have rigors. Okay, so most of these things you will not see. They are not signs. Most of them are symptoms. When the malaria becomes severe, you'll find that they will manifest as cerebral malaria, where the patient will be delirious. Patient may even go into a coma. Okay, and then the patient may present as having a severe anemia. Severe anemia patient may also present with renal failure. Renal failure, which is normally acute when it comes to malaria, it's a complication. When managed well, it is reversible. So how do you diagnose malaria? Here are some of the investigations you carry out in order to diagnose malaria. First of all, you have a history, you do a history taking. Obviously, you ask them what the problem is. They're going to tell you they're suffering from what they're suffering from. They'll tell you they have a headache, they've been feeling tired, they've been vomiting, they've been nauseous. They'll tell you all those. So history, physical examination, you do it, you check the temperature of this patient, which will be elevated sometimes up to as high as 40 degrees Celsius. You take a thick or thin blood film slide. So you take a blood slide, and when you take to the lab, it will demonstrate that there are parasites in this blood stream of this human being. And you can also do a rapid diagnostic test, also known as, which in short is called RDT, which will detect the enzyme produced by the parasites. Okay, it will detect the enzyme produced by this parasite. And so you can also do a full blood count. A full blood count will show you things like how much red blood cells are there. This patient should not have anemia as a complication. You should be able to manage it in time. Okay, so you do a blood sugar test to rule out hypoglycemia. Most of these patients who have malaria may be hypoglycemic. You can do a lumbar puncture. Lumbar puncture, take the cerebrospinal fluid to the lab and uh, rule out rule out meningitis. And then you can do a blood culture. Get this blood, take to the lab and rule out sepsis. And then you can do a liver function test, see how bad the liver is, a renal function test to see how bad the kidneys have been affected, renal function test. You collect blood to take to the lab to do a renal function test as well as a liver function test. Okay, you do electrolyte concentrations to see how much, how concentrated the electrolytes are. Right. So, what is the treatment of malaria? The first of all, you want to treat the malaria itself, so you use antimalarials. So the first line of treatment in Zambia is artemether lumefantrine, which is Coartem. Okay, now this is used in uncomplicated malaria. All right. So this is only not used when it's contraindicated. For example, in pregnant women, you have to be very careful at which stage this pregnancy is in order for you to decide what medicine to use. So when it's not, there's no contraindication. The first line treatment is Coartem. Okay. The other drug you can give where there is a contraindication of Coartem is Fancida. Fancida SP, okay, sulfadoxine pyrimethamine. You can give Fancida in complicated in malaria where there is a contraindication of using Coartem. Okay. So this is the Fancida is the first line in second and third trimester of pregnancy. All right. And it is also given for intermittent presumptive treatment. So where you want to prevent malaria, pregnant women are given Fancida in the second and third trimesters of pregnancy. And then quinine is first line treatment in the first trimester. When a woman is pregnant, in the first trimester, you give quinine. Okay, that is the first line treatment. Now, this, as long as the patient is pregnant and they're in the first trimester, you have to give quinine, whether or not the malaria is complicated in that particular humans. Okay, so artemether lumefantrine contains artemether 20 milligrams and lumefantrine 120 milligrams. This is Coartem. Indications are uncomplicated malaria, so it should be given to children. It should not be given to children below the age of 5 or below the weight of 5. So not for babies. So you give the first dose. The way it's given is that you have to calculate. You give the first dose at 0 hours. 0 hours can be any time. The time you're starting is counted as 0 hours. You give this first dose. So for example, if the person comes to your unit and you give them the first dose at 10 hours, you have to calculate 8 hours from that 10 hours, all right? Don't just tell the patient it's BD. No, you have to calculate 8 hours after that initial dosage. So if you've given them the first dosage at 10 hours, 10 o'clock in the morning, you are going to want to give the second dosage at 18 hours in the evening, okay? 6 o'clock in the evening, you give them the second dosage. Okay. After you give them the second dosage at 18 hours, you have to count 12 hours later. 12 hours later, that is when you give um the next dosage. Okay, so you give the first dosage at 0 hours, then you give the next dosage at after 8 hours of the first dosage, and then the third dosage will be 12 hours later, and then the next will also be 12 hours later. All right, so from 18 hours, that was the second dosage, you count again another 12 hour, you count a 12 hours, and then you tell them to be taking now 12 hourly, which is BD now. All right. So this patient is now going to take BD for 2 days, because the first day you had given them at 0 hours and after 8 hours. Side effects of Coartem include the patient may have sleep disorders, patient may have headaches, dizziness, palpitations, itchiness, all right, rashes, abdominal pains, diarrhea, but obviously it's not everyone that is going to develop these side effects. Now, what about quinine? How do you give quinine? All right. Quinine is given at 10 milligrams per kg body weight, 8 hourly for 7 days. So you calculate if this patient is weighing, for example, 50 kgs, you're going to calculate 10 milligrams per kg body weight. That means 50 times 10, okay, times 10 milligrams per kg per kg body weight. So if this patient is weighing, for example, if this patient is weighing, let's give an example of, let's say, 60 kgs. If this human being is weighing 60 kgs, and so you're going to give 10 milligrams per kg body weight, and so this human being is going to receive 600 gram to 600 milligrams, okay? 600 milligrams of quinine every 8 hours. So they're going to receive 600 milligrams of quinine every 8 hours, okay? So now you're going to put this, sorry, not 600. They're going to, yeah, the patient is going to receive, yes, they're going to receive 600 uh, milligrams of quinine every 8 hours if it's oral. Okay, so quinine oral, you're going to give 600 milligrams of quinine every 8 hours. All right, that is in when the malaria is not very severe, patient is able to talk to you, you are able to conversate properly, you can give them 600. Okay, you're going to give them 600, you're going to give them 600 milligrams of quinine every 8 hours for 7 days. However, when it comes to IV quinine, okay, intravenous quinine, you are going to give 20 milligrams per kg body weight. So you're going to give 20 milligrams per kg body weight, and you're going to dilute this in 5% dextrose. You're going to put in an infusion. You put this drug in this 5% dextrose. You're going to put in 5% dextrose, 1 liter of 5% dextrose, and you're going to allow it to run for 8 hours. Okay, you're going to allow it, in fact, you're going to allow it to run for 4 hours, and then you let the patient rest for another 4 hours. Okay, you're going to let it run for 4 hours, allow the patient to rest for another 4 hours. All right. Now, after 8 hours, now you have given this quinine, and it has been 8 hours now. So after 8 hours, you are going to now continue with 10 milligrams per kg body weight, which means now you're going to be giving this human being 600 milligrams. Okay, so you're going to now be giving 600 milligrams, and again you will put it in 5% or even 10% dextrose. And you're going to let this fluid run for 4 hours, and you're going to allow the patient to rest for 4 hours. And then you are going to assess how the patient has been. Has the patient improved from the time they came or not? If the patient has improved, you can now tell the patient to start taking by oral. So you're going to tell the patient to start taking by oral. You give them 600 milligrams um, orally. Okay, you're going to give them 600 milligrams orally 3 times a day, and they're going to take for 7 days, 3 times a day, meaning 8 hourly, right? So you're going to give them also, you're going to make sure that this patient, we're going to avoid side effects of malaria, which will be as a result of reduced, because quinine causes the patient to have hypoglycemia, and therefore that is why we're putting this this drug in an IV infusion. So that drug, which is in this case quinine, is going to be put in an IV infusion to prevent hypoglycemia. So side effects of quinine include tinnitus, headache. The patient will have rashes, hypoglycemia, patient may have visual disturbances. Okay, so that is how you treat malaria. So just um, what you need to do is you need to give, first of all, if it's uncomplicated malaria and the person is not pregnant, the first line of treatment is Coartem. Coartem is made up of 2 drugs, and these drugs are artemether and lumefantrine. It is a combination of these 2 drugs. So you're going to give this drug to a person who has uncomplicated malaria. Okay, this uncomplicated malaria in a person who is not even pregnant, you will give them Coartem. This Coartem is given at the first dosage. When the first dosage is given, you have to count 8 hours from the time the patient takes the first dosage. 8 hours from the time the patient takes the first dosage, you give them another dosage. Okay, now this other dosage is given 8 hours after the first dosage. However, the third dosage will be given 12 hours after you've given the second dosage. So you give 8 hours. The first one you will give 8 hours after the first dosage. The second one you give 12 hours after the first dosage, the second dosage, sorry. And then you will tell them to take 2 times a day for 2 days. So in total, this patient is taking for 3 days. However, in complicated malaria or in pregnancy, you are going to give quinine. Quinine can be given both orally and in IV infusion. So when you're giving quinine orally, you're going to say the patient should take 10 milligrams per kg body weight. Therefore, if this patient weighs 60 kgs, you're going to multiply 10 milligrams times 60, which is going to give you 600 milligrams. Therefore, you're going to give this human being 600 milligrams of quinine to take orally for 7 days. You tell them to take it 3 times a day for 7 days. However, in complicated malaria, where the patient may even be in a coma, you're going to commence this human being on IV quinine. Now, this IV quinine should be diluted in 5 or 10% dextrose. Now, this time, you're going to calculate 20 milligrams per kg body weight for this human being. When you calculate 20 milligrams per kg body weight, you will find that if this human being is weighing 60 kgs, you are then going to give 120 milligrams of 1,200 milligrams of this quinine. And so you're going to put 1,200 milligrams of quinine in an IV infusion. You're going to let this IV infusion of dextrose 5 or 10% to run for 4 hours. You let the patient rest for 4 hours, and then you will come back and put now 10 milligrams per kg body weight of quinine in this same another 5 or 10% dextrose, and let it run for 4 hours. And then you are going to assess the patient and see if the patient has improved or not. If the patient has improved, you are going to change from giving them IV to oral. Oral, you calculate 10 milligrams per kg body weight, and you're going to be giving them 600 milligrams 3 times a day for 7 days. And if the patient hasn't improved, you continue with IV, you continue giving them the follow-up doses will be calculated at 10 milligrams per kg body weight. Okay, only the first dosage is calculated at only the first dosage is calculated at 20 milligrams per kg body weight. So those are how you are going to treat this malaria patient. Now, when it comes to intermittent presumptive treatment seems you are presuming the patient may have malaria, or you are trying to prevent malaria in this person who is pregnant. Okay, so you give the 3 tablets in the second trimester or at 16 weeks. All right, don't give this drug in the first trimester. You give in the second trimester, and then you give the second and third doses at least 1 month apart. So in total, you're going to give 3 doses in this pregnant woman. The first dosage should be given at 16 weeks, and then you're going to give 3 doses in total. Now, every condition, you have to consider the supportive treatment in every condition of a human being. So you have to consider supportive treatment. Supportive treatment is that treatment which will make the patient feel better. Of course, you're treating this malaria with quinine or with Coartem, but it will not make them stop having joint pains immediately. So you have to give this patient drugs that will make them a little bit comfortable, even as they are taking these anti-malaria treatments. So you want to give drugs such as analgesics, such as Panadol. Okay, any person suffering from malaria should be given a painkiller such as Panadol. Okay, you're going to give this Panadol 1 gram TDS. This is an adult, so you're going to give 1 gram 3 times a day. All right, for at least 3 days. You are going to give antibiotics for prophylaxis. You want to prevent any other superimposed infections in this human being. So to prevent that, you may want to add an antibiotic. Okay, you're going to give an antiemetic, okay, an antiemetic, the drug that will prevent the patient from vomiting. You want to give an antianemic to prevent the onset of malaria, for example, folic acid, especially if this human being, the malaria is very severe. Okay, so there is a lot of red blood cell breakdown. The patient may also have difficulties breathing, so you may want to help them with oxygen therapy. You may want also to give a blood transfusion if it is complicated malaria and you are suspecting that this patient may have anemia, or you may confirm anemia by testing by getting blood and checking it for a full blood count. Now, what are the complications of malaria? Malaria, if untreated, will result in very serious complications. Some of the serious complications include anemia. We've talked about how anemia can come in. It can result in cerebral malaria. This is when the brain is congested, okay? This will happen if the blood vessels that are taking the blood to the brain become sequestered, all right? And so you find that there is congestion in those small blood vessels. Those small blood vessels may start rupturing, and there will be small hemorrhages occurring in the brain, okay? There may be a little bit of some small necrosis that will start happening in the brain, and therefore this patient is going to have cerebral malaria, okay? The patient may have what is known as black water fever, which is also known as hemoglobinuria, due to massive intravascular hemolysis. There is going to be massive breakdown of red blood cells, all right? Which may lead to obstruction of the glomeruli by the products of red blood cell breakdown. Once there is that blockage or obstruction of the glomeruli, there is going to be necrosis. Okay, there's going to be necrosis of the there's going to be necrosis of these passages, and this is going to lead to the patient urinating very dark urine, which may even resemble Coca-Cola. Patient will present with jaundice. I've talked about how jaundice comes about after red blood cell breakdown. One of the byproducts is bilirubin, which may make the skin and the mucous membrane appear to be yellow in color. Patient will have pulmonary edema. We've already talked about how edema may result once there is sequestration in the blood vessels. There is seepage of these fluids from the blood vessels to the extravascular spaces. And so this patient will end up having pulmonary edema. The patient will have hepatosplenomegaly because the spleen and the liver are there's invasion of these organs by parasites, and breakdown of these red blood cells normally happens in large quantities in the spleen. And then the patient may go into acute renal failure due to acute tubular necrosis, which we have already discussed, where the tubules start necrotizing because of those a very high amount of red blood cell breakdown circulating in the blood and settling on um, in the tubules. All right, so they find that there's going to be tubular necrosis, which will result from reduced blood supply to the kidneys as a result of renal microvascular obstruction. Okay, so you find that this person will end up developing acute renal failure. If managed well, this acute renal failure is reversible. The patient will go into hypoglycemia from increased metabolic demand and febrile illness. So the patient will end up going into hypoglycemia. Moreover, the parasites will also use glucose, all right? And so you find that the patient is going to have hypoglycemia, all right? Now, what is the prevention? You have to know the prevention and control of malaria. You have to know the difference between prevention and control. Prevention is where malaria hasn't happened yet in a community. There isn't an outbreak yet, all right? A disease hasn't happened yet, so you need to prevent it. And control is where the disease is already in the community, but you need to control the spread of this disease. All right. So you find that you need to teach the community on how to prevent malaria and how to control malaria. Some of the things you're going to be teaching the community are physical destruction of adult mosquitoes. Now, this can be done by using insecticide sprays. So there are people who do regular intervals of spraying of the houses and the walls in the houses in order to kill the adult mosquitoes. Okay. The other thing you're going to give your to put in the IEC to your patients is to get rid of the breeding areas for mosquitoes. These breeding areas that are near their homes. So you make sure that the patients are told, or the community is told, to drain any stagnant water. There could be stagnant water anywhere. Sometimes you find that there's a block, those blocks that are used for building. That block is seated in such a way that there is stagnant water in it, and mosquitoes are breeding in that stagnant water. So you drain all the places that can harbor or that harbor stagnant water, all the swamps and ponds, okay? And collections of stagnant waters should be drained. Tall grass from houses tall grass should not be near houses. So you should encourage the community to cut all tall grass. Remove of any container around the house that may hold water. Pouring oil on water surfaces to prevent larvae from breathing. Okay, larvicides should be used. Now, protection of an individual should be done now. That we were talking about protection of the whole community or the family, but now at individual level. When people are outside sitting, telling stories in the night, they should be encouraged to wear long-sleeved clothes. They should be encouraged to, the pregnant women should be encouraged to take Fansida as prophylaxis from malaria. Mosquito coils can be used where they switch on they light the mosquito coil so that mosquitoes can be killed, or they can um, go out of the house for fear of the repellents from the mosquito coils. Mosquito repellents, those who can afford mosquito repellents, they can apply on their skin as they sit outside or even inside as they tell stories. Okay. Windows should be closed. Okay, should be closed as early as 17 hours. The moment the sun starts going down, the community should be encouraged, or family members should be encouraged to close windows so that they prevent the entrance of mosquitoes. So windows should be closed. The insecticide treated nets should be used when people should be buying insecticide treated nets to allow these mosquitoes to die once they come in contact with these mosquito nets. Treatment should never be stopped midway. So patients should be advised to finish their treatment. All right. And then the health education to the public should be given on mode of transmission. People should know how malaria is transmitted so that they should cooperate in prevention, carrying out the preventive measures. You should be able to teach your community the signs and symptoms of malaria so that they run to the healthcare facilities before it's too late, and they seek medical attention before it's too late. Okay. So this is the nursing care. You have to add more points. You have to read this nursing care. Make sure you know how to manage a patient with malaria. You should be able to manage a patient who is in Rigas. Okay, in Rigas, there is the cold stage. What are you going to do for this patient who is in cold stage of Rigas? There is the hot stage. What are you going to do for this patient who is in the hot stage of Rigas? What are you going to do for a patient who is in sweating stage of Rigas? So in cold stage, Close nearby windows, give fluids that are warm so that you stimulate the internal temperature. Okay. Put more linen on this human being so that they start feeling hot or warm. Use a hot water bottle. All right. Don't put the hot water bottle direct on the patient's skin. You should wrap it in cloth so that the patient is not burnt. You have to monitor temperature, all the vital signs. Observe the patient constantly. And then when the patient goes into hot stage, you have to help them feel comfortable too. Open nearby windows, remove extra linen so that they can, they can get rid of the extra heat. Give them now plenty of cold fluids. You can tepid sponge them. Give prescribed antipyretic drugs orally. Antipyretics meaning those drugs that work against fever. Switch on the electric fan. When the patient goes into sweating stage, you still have to make the patient feel comfortable. You need to help them wipe off their sweat. The linen that is becoming wet and soiled should be removed, changed. The fan should be switched off, You help tap it sponge and make them feel better. Okay. So this is the nursing care for this person. This is the nursing care for this person. Please go ahead and study the nursing care. Pay attention to the complications, pay attention to the preventive measures. Make sure you add points in this nursing care and finish the eprophenema in this particular nursing care. Okay, so this has been malaria. Study hard and I'll send the notes.